So you just got a mental health diagnosis and you were told to go seek therapy. So you get on your insurance page or any other number of ways and you try to find a therapist. And what you realize is there are no therapists available, right? Or there are, but you have a long, long wait list to get on. So if that's happened to you, you're not alone. The American Psychological Association recently published a report and said that a third of all people trying to find mental health services in this country are not able to find them. And you're 10 times more likely when you're seeking mental health services to seek services outside of your insurance network than for any other kind of health conditions. So this is a really common problem. And we're going to try to answer the question, why is it so hard to find mental health services? I'm Dr. Eric Newman. I'm a licensed clinical psychologist. I've been practicing since 2013, and I specialize in psychological testing. So that's like testing for learning disabilities, ADHD, autism, and any other number of conditions where we're trying to kind of identify what's going on here.
And I'm Dr. Dana Torpy Newman. I'm also a licensed psychologist. I've been licensed since 2011, and I have been in almost any setting you could imagine providing psychotherapy services. Child and adolescent inpatient unit, a veterans hospital, an active duty military base, a community mental health clinic, a university psychological center, and what I've been doing for the last 11 years, my private practice. I've had a private practice in 3 states. And so these are all, and my areas of expertise are relational therapy, mood disorders like depression, bipolar disorder. I love those. And also, I really love to focus on the ways in which we have constructed our society in ways that contribute to our psychological distress and the mental health crisis that we talk about all the time.
So Dana and I are married, and together we are Newman Psych. And this is the inaugural video of our YouTube channel, Newman Psych. And we decided to do this because we see lots of mental health challenges. And frankly, we're tired of trying to treat mental health problems one person at a time. You know, lots of people are having trouble finding services. And not that we're going to do therapy here or solve your problems specifically, but we're hoping to open up conversations that are helpful to people sort of at a larger scale to hopefully reach more than one person at a time. So we appreciate you watching, and we're going to talk about why it's so hard to find mental health services.
The first factor that we're going to talk about today is the reimbursement rate issue. That is actually one of the primary factors that is involved in not being able to find mental health professionals that are in your insurance network. Now, one of the things that you may be thinking, because this comes up all the time, is things like, don't doctors get paid enough? I don't want to hear you complain about the fact that you don't get paid enough in order to provide services. And I want to say, I totally get that. And I want you to understand that the reason that we're talking about this is to help you to understand what the actual situation is here. We're not asking for sympathy or pity. It's more for you to understand, why can you not find people in your network? This is one of the primary reasons. And so here are some details about that. One is that for mental health providers are typically reimbursed at a lower rate than for physicians in general.
And this is actually true in some cases, even for the services that mental health providers provide. So for example, you could go to see a psychologist for therapy, and for whatever reason, insurance companies reimburse physicians who don't actually have training in providing therapy at a higher rate than they reimburse for psychologists, and certainly at a higher rate than they reimburse for other master's levels clinicians.
So there's not a lot of incentive for people to join health insurance networks. And if you think about the implications of having these lower reimbursement rates, most people who have mental health professional certifications also took out student loans to get that. And so the reimbursement rates really impact their ability to pay back their student loans, to support families. Most people would not have a career where they can't provide. And pay for their expenses. That's what this issue is really about.
And here's the other thing: when you have when you go, because we both accept insurance. A lot of people don't. We do, because we believe that to the extent that we can, that's the right thing to do, so we can provide services to people who wouldn't otherwise be able to access it. But when you go to insurance companies to join their networks and you get on a contract, that contract either specifies here are your reimbursement rates and they're fixed, or it specifies your reimbursement rate is a percentage of the national, like Medicare and Medicaid rates. And it could be a lower percentage than the rate. It's based on that percentage, but it could be that it's a decrease from that percentage so that they can kind of make their own profits. Or sometimes they do offer an increase in that percentage. But here's the thing: if it's a fixed rate, a lot of times there's no sort of cost of living increase there. You go years and years without having your rates increased.
So I actually did. So I started accepting insurance, I want to say in 2012 or 2013, shortly after I opened my private practice. And the rates that I was given by the insurance companies, they did not change them until COVID, when I think they were mandated to. That is 10 years without even a cost of living increase, despite the fact that, like, I had student loans, we have kids. I don't know of any other person that would be in a job for 10 years where they're not given at least a cost of living increase. Like, that is the reality for mental health professionals who are trying to do the right thing and navigate a system that is broken, that we're going to talk about endlessly in our videos. Like, that is my favorite topic. So, like,
but here's the other thing. If you have a contract where it's a variable rate and it's based on the national rates, you would think, okay, great. In that case, you get cost of living increases as the percentages increase. But a lot of times we're actually seeing decreases in our rates, not increases. So, you would think year after year those rates would go up, but for whatever reason, they're going down. And that's not something that is sustainable, obviously, for someone who needs to have periodic increases in their rates to maintain a cost of living.
I also just want to add, I'm fairly certain that the CEOs of the health insurance companies have received raises every year that we have been practicing. Like, just letting everyone, the last I checked, they were not providing services. So just wanted to add that part.
But the gist of this is that at these rates, it causes providers to have to see many more patients in order to make a living, which really lends itself to very quick burnout. And so on the one hand, in the mental health field, they tell you it's your ethical responsibility to avoid burnout so you can take care of your patients, in a sort of way that is expected. And on the other hand, there's no way to do that when you accept insurance and have to take their rates.
The last factor in this category is actually one that I shout from the rooftops all the time. It drives me crazy. So just a brief background. Our medical system is based on a symptom reduction model. What that means is that we view progress as something that is like, oh, that negative symptom is gone, great. Versus a functional improvement model, which is like, oh, you're actually living a more fulfilling life. That should be the goal. And so in the current medical system that we have, we are solely focused on symptom reduction. And that means things I always joke around and say, like, I actually don't care if my client is crying fewer days of the week if they are still isolated and disconnected from everyone around them. That's the difference between symptom reduction and functional improvement. And so when you have a medical model that is based on symptom reduction versus functional improvement, you end up prioritizing making medication more accessible than psychotherapy. Medication is really about symptom reduction. Psychotherapy is about taking that symptom reduction and helping people live more fulfilling lives. I want you to understand what this actually means on a monthly basis. So let's say that you go to weekly psychotherapy and your copay is $50 per session. That's $200 for 1 month's dose of therapy. Meanwhile, if you take an SSRI, an antidepressant, like Zoloft, Prozac, Wellbutrin, your copay could be like $8.62 for a month's worth, or sometimes 90 days worth of medication. So you can see that there's an unequal reimbursement for, or an unequal ability to afford a month's dose of medication versus a month's dose of psychotherapy. Just so we all know what the data says that for things like major depressive disorder, depression, the most efficacious treatment is a combination of medication and psychotherapy. But if you make one of those things that is a very important factor in the treatment inaccessible, you are no longer providing what is viewed as the most evidence-based, efficacious therapy that you should offer, or treatment that you should offer. You can see this issue drives me crazy. I'm like leaning forward, wanting to shout it from the rooftops.
On that note, if you're finding this information helpful, please hit the like button, hit subscribe. We're getting this channel started and we're hoping to grow it. Newman Psych, you can also check us out on our website, www.newmanpsych.com. And we also just launched a video course on that website about how to find help for your struggling child. That's a video course that I'm doing, and we'll be adding more courses as well, and Dana will do some as well. So please check us out. And again, like and subscribe so that we can get this information out to as many people as possible.
Our desire is really to pull the curtain back on all of these mysterious processes so that we can all really, really push for change so that everyone can have access to the services that they need.
So we just talked about reimbursement rates. So the next kind of category of challenges that make it not feasible for lots of providers to take insurance for mental health is administrative burden. So, as providers who do take insurance, we're constantly being asked to update our information. And, the intention behind this is certainly good. We want to make sure that our, all of our information is up to date so patients can reach us and so insurance companies know who to direct to us. But we have to do it many times across many different systems because for every insurance, so first of all, there's a general system that we have to put our information in, and that has to get updated every 90 days.
Yes. Maybe it's 180. I think it's 180 days. Yeah.
But then that system is supposed to push out and update all the insurance companies. But then each insurance company requires us to update it through their systems, and that happens more frequently. That I think happens every 90 days at least, right?
Yeah. But why? Why? We have a centralized system. We were told that's why we should do this. So you can see no one has the time to do all of those things.
And then in addition to that, there's all the regular things that go along with each patient that we start to see. We have to verify their insurance. We have to file claims, their utilization reviews to make sure that treatment is being done in a sort of efficient way so that they're, paying for the number of sessions that are warranted and there's not abuse of the system, which is understandable, but that's...
Except I disagree with the model by which they are
right.
saying we should be providing therapy, so that...
Mm-hmm.
Also, there are endless processing errors. And so, how when you try to call like your insurance company or like the phone company or something like that, and you sit on hold for 3 hours and you can't get a human on the phone, you would think that providers would have access to talk to humans so we could get these things done and get back to providing services. Oh, no. I have spent hours. I mean, Eric is at least calm when he's on the phone with insurance companies. I have spent hours screaming at the top of my lungs because you can't get a human on the phone. They don't actually take notes about the conversation you had. And the fact is the error is usually on their part, and we don't get reimbursed for the time that we spend having to deal with them. Again, this is a situation where no one has a job where they're not paid for the time that they're spending doing the job, other than mental health providers who are having to call these insurance companies and deal with all of these things.
Right, and you might be saying, boo-hoo, doesn't every health provider have to deal with these same things when they accept insurance? Yeah. Well, no, a lot of these things they don't. A lot of these things they do, but here's the difference. The reimbursement rates for mental health providers prevent us from hiring people to do this. When you go to your physician's office, your primary care physician or any specialist, they have an army of people that are hired to, just deal with this stuff. And that's all they do. Many mental health providers are actually in private practice because the reimbursement rates are so low that when you go to work for somebody else's practice, you're not only getting paid what those rates are, but you're getting paid less than that because the company you work for has an overhead. And so what happens is we end up working for ourselves, which we do, and we can't afford to hire somebody to do our billing, do our verifications, or dealing with these processing errors. We have to do it all ourselves. And so that really makes it nearly impossible to be able to accept insurance and still provide care.
I also want to point this piece out because, again, you may be sort of rolling your eyes and wondering, like, why should I care about this? The reason is what you get from seeing a provider that's in private practice, like a small practice like Eric's and mine, is you feel like we know you. You feel like we care about you. We have a relationship with you. You can get us on the phone if you have questions about things. And so that's the trade-off. This is not the same as like, well, my doctor said that this was going to be provided, and then you get the non-doctor on the phone or the non-provider on the phone answering your questions. Like, we are it. And so that's great. Like, one of the things that I love about private practice is it feels like a community business. I love that feeling. I'm very much about like social connections and feeling like you can provide support for your fellow community members. That is the positive of this arrangement. But these are the reasons that you don't see a lot of providers accepting insurance, because they can't sustain that level of relationship with you and address all of these bureaucratic, nonsensical things.
All right, so we've talked about reimbursement rates. We've talked about administrative burdens. The third kind of main category of challenges that providers face that make it difficult to be in your insurance network has to do with limitations to the services that we can provide.
Okay, I want to talk about the first one, because the first one is also something that like you're going to be so angry when you know this. Okay, so this falls under the category of artificial provider shortages. When we lived in the first state that we practiced in, I was trying to get into various insurance networks, again, because we feel like it's the ethical thing to do to accept insurance. And I would call up, I would get tons of calls from people who had a specific insurance company. And it was not just one, it was multiple insurance companies. And they would be like, hey, I'm looking for a provider. It looks like you specialize in what I'm looking for. And I would call up the insurance company. I would say, hey, I'd like to join your network. A ton of your patients are calling me because they can't find someone in their network, and I'm happy to join your network. And they would say to me, we have enough providers in this zip code who are offering the same service as you. That is what an artificial provider shortage is. I was begging. I was saying, please, I will happily join your network because I want to provide these services. No, we have enough providers. And I would say, like, but you don't, because your patients are calling me. They're saying they can't find someone. Did not matter. This is what insurance companies do. They limit even people who want to join the network from joining the network, because then they don't have to pay for the services.
So that is certainly the most infuriating of these challenges.
It's so infuriating, right?
But other limitations that we come across are insurance companies will often, this kind of goes along with the utilization review I was talking about earlier, they'll only approve a certain number of sessions in therapy, or I'm going to talk about assessment in a minute, but there are limitations to what they're willing to approve. And then you have to actually spend a bunch of your time in order to argue for more time if you want that. And then you've just spent the time
to someone who does not know your patient.
Right.
And also remember, we're back to what is the medical model? Symptom reduction versus functional improvement. Mm-hmm. Symptom reduction is something you can do in 10 sessions. Functional improvement is not. And that is the argument. And when you argue with people who don't believe that the model is broken, you're going to hit a wall. And that's really, really frustrating.
And here's the other thing. People move all the time, right? Or people change insurance networks all the time. They change
lose
jobs,
their jobs.
Right? Because our insurance system is tied to employment in a lot of, in most cases. If someone moves, they lose their job, they change their job, or they just change their insurance. Some jobs offer multiple insurance carriers as options, and they change their insurance. If you as a provider are no longer in the new network, then you're forced to either abandon your client or, work pro bono, or, they want you to kind of work on a pathway to, moving your client to somebody else. That's oftentimes very counterproductive to treatment.
Also, I have this happen many times throughout my career. My clients lose their job, they lose their insurance, they are psychologically more distressed than ever. And I'm supposed to do what? I'm supposed to send them to a new therapist when they don't have insurance and are not making an income? I'm like, what are we supposed to do in that situation? Because our insurance is tied to our jobs, that is a real obstacle to providing what we also say we value, continuity of care. That's what this idea is. We talk about this in medicine all the time, but it's especially true when you're building a therapeutic relationship with someone. In therapy, you talk about really deep, meaningful, uncomfortable, vulnerable things. Shipping someone off at their most vulnerable time is really, really unethical and counter to all of the things we are trained to do. But this is the position that we are placed in because of these artificial limitations that insurance companies place on us.
Mm-hmm. Yes. So those are the three broad categories of challenges that clinicians face with taking insurance, and a lot of the reasons why you, as a patient, have trouble finding people in your networks. I want to just close out this video by talking about my area of specialty, which is psychological testing, because if you think you have a hard time finding providers to do therapy, try getting an assessment done through insurance. It's even harder. Almost nobody takes insurance to do these evaluations. And there are reasons for that, because as low as the rates are in general, they're even lower for assessment. So you would think that when somebody has a specialty area, that person would be reimbursed even more than the typical reimbursement rate, maybe, or at least not lower. You would also think, given that assessment requires stocking up lots and lots of tests, lots and lots of test protocols that need to be replenished on a regular basis, tests that kind of get new versions come out and we have to buy new versions. So there's a lot of overhead in the testing area that doesn't exist when you just do regular therapy. So of course you would think that for that you would get reimbursed more, but instead rates of reimbursement for testing are lower, and in many cases significantly lower, because they basically treat testing as if it's something that can be done by a technician. There are different rates, and they made it extremely convoluted, but basically there are rates for the interpretation of test scores and writing of a report. There are separate rates for test administration and scoring, and they act like, at least for the test administration and scoring, that can and should be done by a technician, so they can pay a technician much lower than they can pay a psychologist. What they don't realize is that
they realize, to be clear, they realize.
Yes, they realize.
They don't care.
Just as important as the test scores that come out of these tests are the behavioral observations, the things the person is doing when they're taking these tests. That adds so much to the interpretation of the test results. And if you have a technician doing it, you're relying on that untrained technician to convey those things to you rather than seeing it for yourself. So, it's a really bad position to be put in. So the rates are terrible for psychologists to do these things. In addition to that, a lot of times there are pre-authorizations that are required, and guess who has to do that? I do, and it costs a lot of time and effort to do that. As I mentioned to before, or as I alluded to before, the billing and the kind of the different rates for the different kind of codes and units, they're so hopelessly convoluted that we have it's like we bill this number for the first hour or the first 30 minutes of what we do for testing, test administration. And then for each additional hour, we bill this other code. And then for the first hour of interpretation or report writing, we bill another code. And then for additional hours, we bill another code. And then, it gets so confusing, and it adds so many points at which insurance companies can A, make mistakes, and B, just decide that they're not going to reimburse for that the time that it takes to deal with that it's just not feasible for most people. And then the other thing is, two other things. Number one, oftentimes they're limiting the number of units that you can use for testing. So they're basically saying they like to tell people that they don't do this. They say, oh, there are no hard limits to the number of units, but they do have documentation that says here's the standard of care. It's not realistic. And then they say, well, we're not going to approve we're not going to approve what you submitted because that's beyond the standard of care. And then, of course, I have to spend another hour or two arguing for why I want another hour or two worth of units, in which case I just spent all the time that I would have gotten from arguing for. So, I mean, it makes it impossible. And then the last thing is that a lot of people look for testing for their kids for academic reasons. They want to do things for school. They want to see changes. They want to get an individualized education program or a 504 accommodation plan or something in the school setting. And so parents want to, come for that. And what they don't often realize is that insurance rarely pays for academic testing. So testing of reading, writing, math skills, those are viewed as being within the school's purview. And so they don't pay for that. And they don't even really pay for a report that's helpful, even for the clinical data that you collect, that's really helpful for educational purposes, because it's really meant to be a summary report, a brief report that has, it's for clinical purposes. So all of these things make it really difficult to provide people with the assessment that they need for the insurance rates. And I would honestly rather just not even try to do that than, do that and do a poor job of it. So that's why when it comes to assessment, it's even more difficult to find a provider who's willing to take insurance. And like I said, I do take insurance. Dana does. I've had to actually cut down on the number of different insurance companies I work with because of all these challenges. And I may be on my way to cutting out all of them at some point because it's just not sustainable.
So welcome to learning what's behind the curtain in the medical system so that you can better understand why you are having trouble accessing services.
All right. Well, thank you for tuning in. Thank you for watching our inaugural video. Again, if you enjoyed this, if you got something out of it, please please subscribe, please check out our website, check out our course videos. There's one right now, but at the timing of this, recording, but hopefully we'll have more on there soon. And thanks for tuning in.
We'll see you soon.